So I'm really sorry. I will try not to cough into this and cough on you guys. Okay, so I'm talking about the pharmacist role in the ICU and the CRRT program. This is a new topic for me to deliver to you guys this year. And I'll say it was a little bit challenging to develop an applicable talk for everybody. So I'm hoping what we can do is have more of a conversation, a back and forth about what you guys are doing, what you're seeing. So here are my disclosures. So 3 big objectives. Because I'm on this stage and I have the ability to, I'm just going to talk about what do pharmacists do in the ICU. We're just going to do it because I think there's a lot of metrics here and there's a lot of data here, and I think this is just good overview. We're going to talk about the CRRT quality assurance, quality improvement, pharmacist activities that I've been a part of. So this is really my experience. If it feels like it's the UK way, it's because this is my experience. So that's a disclosure. And go through some of the examples of projects we've done and how we've been able to utilize some of these resources to move the needle on our outcomes. And then finally, we're going to go through a patient case. We're going to highlight ways to improve medication selection and safety for our patients requiring CRRT and the patient coming off of CRRT as well. So starting off, what do pharmacists do in the ICU? So we have a couple pharmacists here, not a lot, lots of nurses. And I feel like sometimes nurses are just our best ally for, the multidisciplinary team. What can we do? What can we get done for these patients? There's been a lot published over the years on what should pharmacists be in the ICU? Why would we need a pharmacist in the ICU? And then what kind of outcomes are associated with pharmacy interventions? And what does that look like? Generally as a profession, we're still a consult profession. So we don't get to bill for our activities. We don't get to bill for our cognitive time. A lot of the old school thinking about pharmacy is, well, what cost savings initiatives do you have going on? And how can I justify positions based on that? And so the profession as a whole is trying to move towards away from being attached to a product and towards cognitive services and hands-on patient care. So a lot of the recommendations, and I would refer you to this position paper. So SCCM has published this in conjunction with other pharmacy organizations. This was the 2020 update, and it really talks about what do critical care pharmacists do for ICU patients. The activities are broken down into essential and desirable. And this is probably similar to what you all see in your institution. So if I could just get a quick poll of the audience. How many of you do not have a pharmacist rounding with you on your ICU teams? Okay. How many have a pharmacist Monday through Friday, but not on the weekends? Okay. How many have one on the weekends? Oh my gosh, that's fantastic. Like on rounds on the weekends? Wow. Wow. I'm really impressed by that. That's fantastic. Some of our hospital metrics and benchmarking, like the leapfrog scores, for example, actually look at pharmacy coverage rounding services on the weekend. And so this is moving towards more of a quality and care-based bundling for patients. But it's still, there's still a lot of battles that we fight to get pharmacists into the ICU. So we regularly round with the interdisciplinary care team. You guys know that, you see that. My practice is actually in the medical ICU. So my whole perspective on nephrology and all of it really comes from NICU patients. We provide pertinent comprehensive drug information to the critical care team, evaluate the medications, every medication every day. Patient needs to have the right drug, the right dose, and the right duration and the monitoring that goes with that. Pharmacokinetic monitoring, medication reconciliation. Do you guys have technicians do medication reconciliation? Yeah, so we do as well. And that's, utilizing pharmacistic centers in that way has really been able to elevate patient care. And then we have the desirable, which is independent patient assessment. And so there are some hospitals, pharmacists do independent pain, agitation, delirium, nutrition assessments. There are some hospitals that have pharmacists go to stroke alerts and complete that NIH stroke score and are responsible for evaluation of TPA in conjunction with neurology. We do that, but I'm not trained to do the stroke score, and I kind of don't want to do the stroke score. but like that is something that we're capable of doing, right? ACLS, of course. And then the last one on the list, involved in non-patient care activities, right? Include interdisciplinary committees and educational lectures. And so that's really what we're focusing on today, and how can we bring this, what's been published about ICU pharmacists, to acute care nephrology. So I found this editorial in Intensive Care Medicine, which is the #1 ranked ICU journal that we have. It was just published recently. It's 10 reasons for the presence of pharmacy professionals in the ICU. And it just instantly made me think of the movie 10 Things I Hate About You, but 10 Things I Love About Your ICU Pharmacist, right? And so it's a really quick read. It's 2 pages. It's fantastic. And it was just like a really good, a feel-good read for me, right? Because it's good to see this come from our European colleagues. This isn't even American authors here. And it's really nice how it highlighted the role of the pharmacist and how we can improve patient outcomes. There's a 2019 meta-analysis that has looked at the pharmacist as a member of the ICU team, and it showed that having a pharmacist on the ICU teams, as opposed to not having a pharmacist, patients have lower mortality, 0.78. It's almost a 30% reduction in mortality by having a pharmacist on your ICU teams. That same paper looked at pharmacists that can reduce ICU length of stay, so 1.3 days. And this editorial highlighted that. And a couple of other data I want to bring to you guys. So our group published a meta-analysis last year looking at antibiotics dosing in sepsis. So which hospitals here have a sepsis bundle, like a code sepsis? Okay, you guys are like up there. I'm like so impressed. So do you have pharmacists responding as part of that? Do you guys know? Yes, maybe. So maybe a couple of wiggle hands, yeah. So if you have a pharmacist as part of your sepsis response team, based on our meta-analysis of the available literature, there's only like 5 or 6 papers that we were able to really include, it will decrease time to first dose antibiotics in sepsis. And there was one paper that looked at decreasing or improving effective antimicrobials. So, you know, not everyone should get Zosyn. Some patients need meropenem, some patients need Zerbaxa or cefetrexone. Like that evaluation done by a pharmacist can improve patient care. Another paper that was published in 2020 looked at pharmacy-driven diuresis protocol. And so this is another one of our papers that we did. This was my colleague in the medical ICU. We designed this protocol to help volume deresuscitation, right? So we were struggling with patients getting 1 dose of Lasix, no monitoring, and the next day we're still fluid positive. And so we're like, okay, we need a better way to do this, right? And so are you guys familiar with the FACT trial, fluid and catheter trial? Kind of like the underpinning of all ARDS care. And so it's the conservative volume management. We know those patients do better, ARDS patients do better with lower volumes. And so we've been talking about volume overload all week, but that's not new. I mean, the FACT trial was published like what, 2006? So old data, right? So we kind of took that and said, okay, how can pharmacists get involved here? So this is like an extremely multidisciplinary protocol that we created. Pharmacists help identify patients eligible for the protocol, the accurate first dose of your Lasix dosing. So this is based off of weight, current serum creatinine, prior response to diuretics. Are you diuretic, loop naive or not? And then we have our nurses follow up with activatable orders if the patients aren't meeting their Q8 balance. And we have a couple of our MICU nurses in the room. And so I know it was kind of hard for us to kind of execute this in the beginning, but it ended up having a really positive impact for our patients. And so this paper got published in Critical Care a few years ago. So the pharmacy-driven diuresis protocol decreased the 72-hour post-shock cumulative fluid imbalance. So protocol patients were minus 2.2 liters at 72 hours after pressors came off versus the controls that were positive 265 mils. It was also associated with a decrease in hospital mortality and higher number of ICU free days. And then another study looked at pharmacist involvement with status epilepticus patients. So do your hospitals have a code status epilepticus or like a response team that goes to seizing patients in the hospital? You guys do? Yeah. So we do too. It's not utilized as well as it should be. But this paper looked at the role of a pharmacist's involvement in those types of protocols. And so a nurse or provider or anyone this patient is seizing, we need stat emergent like resources here for the patient, right? So the pharmacist's involvement improved selection and delivery of the anti-seizure medication. So the first medication went in faster, 26 versus 37 minutes, which isn't that long, but time is brain, right? Not statistically significant, but might be clinically significant for some patients. And improved time to second line agents, which is like a huge change here, 51 versus 171 minutes. And there are many studies like this out there. A lot of these are single center, you know, a pre-post intervention. And so the methodology is not on the RCT level, but there's a lot of reasons why we should include pharmacists in the ICU. And so that editorial highlighted some of the things that I've just spoke about. So the 10 things to love about your ICU pharmacist, right? I like this little graph. So pharmacy outside the ICU versus inside the ICU, right? So we can expect better outcomes, improving drug safety, improving evidence-based therapy. I think that's one of the biggest things I do is help drive evidence-based care. Therapeutic drug monitoring, of course, you know, I love math. Transitions of care, research, education, you know, continuity in drug supply and cost benefit. There's actually a lot of cost avoidance and cost benefit literature looking at pharmacists in the ER, pharmacists in the ICU. And so there's a lot actually published there. So we've gone over what do pharmacists do in the ICU, but what do they do for nephrology QI teams, right? That's really kind of what I'm here to talk to you guys about. And so there's much less published here. So I did my good pharmacy effort, I did a PubMed search to see, well, what are people doing on CRRT QI teams? And there's nothing out there about it. So maybe I should write that paper and get it started. But so these two papers were published over the last few years looking at, well, what does a QI team do for CRRT patients? And I think we're still on that level. We're still on like, how do we build this? What's the need? We need to identify the need. We need to identify the gaps and start to fill this in. And I know you just had an excellent talk by Javier about how we did that at University of Kentucky. And so within this, it's still not even really clear, what's the pharmacist role? Like, what do I do? So I don't know, what do I do? And so that second paper, the Vagshaw paper, actually had a list of indicators that included medication adjustment. I don't know if you guys can see. You can see kind of in the middle, medication adjustment, I kind of pulled out as a very pharmacy-centric indice. So yeah, we need to make sure we're getting medication dosing right. And so they suggested that this should be monitored monthly in this paper. And we should be looking at the number of adjusted medications divided by the total number of medications that should be adjusted. That sounds reasonable, right? So did you adjust your beta-lactam? Did you adjust your vancomycin? Did you adjust your famotidine? Whatever, what have you. But how do we do this? So who here measures that monthly in your programs? Which medications should be adjusted for this patient and which ones are? Does anybody measure that monthly? Like, we actually don't measure that monthly. And so I wanted to bring this back to you. Well, what do we need to make that happen? And so these things are in the literature. This is hitting the guidelines and recommendations. Expert consensus panels are saying we need these things. But how do we operationalize something like this? This is much harder than, I would say, bleeding events, CLABSI events, those things we kind of track routinely. And this also needs to have some clinical assessment into it as well. So what drugs should we adjust and whatnot? And so I'm going to pose this question, like, how do we accomplish this? I think to me personally, this is going to require some type of routine and systematic data mining from your EHR. Probably going to require some type of guidelines so we know, okay, these are the medications that we're looking for. Was this dose appropriate? And then the assessment thereafter. And that requires a lot of manpower. So these things seem simple. Yeah, we should track that. But how are we going to track that? It's not easy. It's not as easy as we would think. And so this, I created this little, I don't know, organizational chart of what I do and who I interact with and how I do this job. And I want to walk you guys through it because after I completed this, I realized this is pretty complicated. And I hadn't really thought about it in this way. Like, what are all the activities I do for our QI team? And how do I interface with the rest of the enterprise? We have over 1,000 beds at UK. We have over 300 ICU beds, and we're just growing. We just bought like another hospital last week. We have 2 towers we're building. And so this has changed a lot, what this looks like. So I'll start you guys from the left to the right. And we're going to start on the top, go all the way across, and then we're going to go through each one. So CRRT, Quality Assurance Pharmacist, that's me. Should put my face right there. So the first group I interact with is our QI team, our QA program. And so we meet monthly to quarterly. It kind of fluctuates. And within that, I have several kind of hats that I wear. And so our branch here is QI and research, and then education. And those are the big things that I bring to this committee meeting. And so as far as QI and research, what do we need to do that? So we need to know, well, what are the problems? How can we objectively measure these problems? We're not just going in with anecdotes and complaints. We need to be able to say, okay, this is what we need to work on. This is what we need to look at. That requires data. We had good access to data. We're having some challenges now, but we've started to build out a really large patient database of all of our patients on CRRT. We have a CCTS at our institution as well, so they're able to pull this data for us, which is amazing. And I don't take that for granted because I know a lot of institutions don't have that. But even within that, we need manpower to clean that data, validate that data, and then analyze that data. And that takes time and people and dollars. And so some examples of those programs that we did with QI and research, the FOSS solution, MUE, I talked about that yesterday. I'm going to present some of the results of these things in subsequent slides. The hyponatremia evaluations, we talked about that protocol. And then I've been involved with industry sponsored clinical trials. And so I've led a couple, I've been co-I on a couple. And in a recent example, we were a study site for cefiderocol, which is one of our newer beta-lactam, anti-pseudomonal beta-lactams, dosing in CRRT. And so I enrolled 3 patients for that trial, and we're putting that abstract to ID week here soon. And so I get contacted through folks across the country because they know we have a big program. I'm heavily involved. And this just keeps us kind of in the loop here. And so we have another pharmacist that has more dedicated time for more NIH level research and more industry sponsored studies. So I'm more on the QI side of this because I actually have another full-time job. So this is like, I just squeeze this into the margins of my day, basically. As far as education for the program, I participate in nursing super user training. We've been doing that for several years. And that's a 15-minute, just real quick, hey, this is what your pharmacist is going to do. This is why we care. This is what volume of distribution is. This is why when you turn off that propofol in your morbidly obese patient, they don't just wake up. That's why, right? So trying to bring back a lot of these bigger concepts that help drive decision-making, but bring it to their, a reference that they can very quickly understand. Like, oh, God, that makes a lot of sense, right? And then I've given multiple pharmacy grand rounds, nephro, pulm, fellows conferences, et cetera. So I'm involved in these educational things throughout the year. So going back to the left branch, the pharmacy subcommittee of the ICU committee. So I represent our acute care nephrology teams and patients here. And in this meeting, I meet with other pharmacists from other ICU areas. So I have here cardiovascular. We have a big ECMO program, our trauma pharmacist. We have another MICU at a sister hospital down the road. And so making sure that we're all on the same page. So they help provide clinical insights, feedback to the program, like what are we seeing, what's going on, what are providers doing and thinking. And then the next pink box is really where we're doing a lot of our optimization. So we switched to Epic 3 years ago, feels like yesterday, because we still have problems with it. So we have an Office of Pharmacy Value Analytics within the pharmacy department that was really built out to help with the Epic optimization phases and just kind of own medication evaluations and own some of our QI. And so with this, I work with our Willow team, the pharmacy Epic team. I've been involved with pediatric and adult order set changes. We just switched to the ST series filter. And so all of that with the heparin priming solution was a little bit challenging to build out and making sure that the heparin is going to trigger allergies on the patient's profile and all these things. With the dysnatremia protocol that we have that we were talking about yesterday, we were able to evaluate some of the data utilizing this office. And so I have kind of different branches of people I can go to for different data sets. None of them are complete or perfect. There's always going to be holes. This is another resource that I have. And then the yellow on the bottom is our antimicrobial stewardship subcommittee. So I sit on this committee as the MICU pharmacist, But I also, I am the one who's created and, verified with our nephrology team and our QI team, our dosing protocol for medications on CRRT. And this goes through this subcommittee as well for approval and final, kind of stamp of approval. So when I sketched all this out, I realized there's a lot here. There's a lot of moving parts. I mean, this could be so much bigger because as we know, and we've been talking about all day today and yesterday, there's so much that we could be doing for these patients and these programs. And yet we're just kind of scraping together people's time and energy and money wherever we can to get this done. And so maybe in the next year or two, this will look a lot bigger. I'll have a lot more squares on there. So I'm going to move into some of the projects that we've done over the years and have talked to you guys about some of the results that we've had. So the first one was looking at our Foxilum experience. We talked about this yesterday in the workshops, but this really started as a medication use evaluation. So, is this drug doing what it should be doing? Are we decreasing phosphate replacement? Are we minimizing hypophosphatemia? Are we moving the needle on any of that? So we designed a single center retrospective before and after cohort study, about 3 years, 1,500 patients, around that many. We had the primary outcome was incidence and the burden of hypophosphatemia. We also looked at the incidence of severe hypophosphatemia, then total phosphate supplementation and glucose levels. We talked a little bit about one of the downsides to this solution is its lack of dextrose, a potential side effect of hypoglycemia and all these other things. So what we found was that we had a statistically significant reduction in hypophosphatemia in the patients on the phosphate-containing solution. And you can see that here in the first graph on the left. So our incidence went from 62 to 21%. The burden of hypophosphatemia, we define this as the number of phosphate readings below the range divided by the total number of readings for that patient that day, also was reduced quite a bit. So 14% to 3.5%. We also looked at patients with hyperphosphatemia. You can see that as the third highlighted variable on the bottom in the middle here. And so and we talked about this, some people were asking too, would you see hyperphosphatemia with the solutions? And you can see yes, 20% of our patients versus 14 had hyperphosphatemia as well. And so we built a regression model to control for other variables that might be associated with hypophosphatemia, including baseline phosphate, duration, time in the ICU prior to start of CRRT. So these things that would associate with the outcome. And we found that the use of a non-phosphate solution was associated with an 8.5-fold increase in the odds of experiencing hypophosphatemia. And so that was highly significant. And the other thing we found in this study too was a reduction in ventilator days. And that sparked us to start thinking about, okay, we know that hypophosphatemia is bad for our patients in the ICU. That goes back to the 1950s when they were pulling phosphate out of sheep and measuring diaphragmatic twitches and then giving it back to them. I mean, that's not new, right? But these are new therapies and these are sicker patients and we're treating more people. And so maybe we're seeing this manifest in a different way. So we'll get to that in a second. So some of our secondary study outcomes as well, total phosphate replacement went down significantly. And on the bottom three, you can see our glucose balances as well. So the minimum glucose was reduced about 10 points here on this analysis. We also decreased the maximum glucose and the median glucose. And so when we're talking about hypoglycemia, it's definitely something you want to be monitoring if you're going to be switching to this solution. So the finding of reduction of ventilator days was really intriguing to us. We did not design that first study to look at that. And not everybody was even on the ventilator. So we're like, okay, let's go back to the drawing board. Let's pull out the patients that were on the ventilator on CRRT at the same time and reanalyze this to make sure we're seeing what we think we're seeing. So we redesigned a single center retrospective propensity matched cohort study to evaluate the impact of phosphate containing solutions on the outcomes of mechanical ventilator free days, ICU length of stay, and hospital length of stay. And for those of you who aren't familiar with mechanical ventilator free days, it's basically the subtraction of total ventilator days that the patient's on, truncated at 30. So it's a validated outcome in the critical care literature that accounts for early death. So we ended up with about 1,000 patients once we excluded folks who weren't on the ventilator or weren't ventilated near the time of CRRT. And the first thing we wanted to do was, is this solution still doing what we saw it doing in the first paper, which is decreasing the risk and overall incidence of hypophosphatemia. And these two graphs are similar, the same patients. The first one's first 5 days of CRRT. The second one goes out to 14 days. You can see the phosphate-free solutions are in red. The phosphate-containing solutions are in blue. And you can see most patients started on a level around 5.5. They really were very evenly matched when they first started therapy. The phosphate-free patients had a big drop, however. I mean, on day 2, big drop. Phosphate-containing patients also dropped because we're dialyzing them on a level of phos that's less than 5, so they are going to come down. And you can see that these were statistically significant in this cubic spline analysis. So for the primary study outcome of ventilator-free days, we did see a statistically significant difference in the two groups. And the way to interpret this is a little bit different because of the skewed data. We had to log transform it. So to interpret this, so the patients who received the phosphate-containing solution had 12% more ventilator-free days than the patients who did not receive that solution. So it's a continuous outcome. It feels weird to say percent more days, but that's the way we had to analyze these data. The patients who received the phosphate-containing solution had 17% fewer ICU days and 20% fewer hospital days. So these were significant in our models. So the next project is not published in the literature yet. So this is an abstract that we brought to the AKI CRRT meeting a month ago or so. This is a quick initial evaluation of our hyponatremia protocol. So we designed a non-randomized retrospective cohort study to evaluate the effectiveness of our hyponatremia protocol on serum sodium changes in the first 24 and 48 hours of CRRT therapy. We included adult and pediatric patients admitted from 21 to 23. Because we switched to Epic at that time, I'm using slicer dicer data with this, so it's not as great as it could be. And we have had this protocol in place since 2017 or something like that. So we have actually many more patients to evaluate. This is just kind of a snapshot of the last couple of years. So we included patients if they had a baseline sodium less than 120 for this analysis. There were patients who had sodiums of 120 to 125 who received the protocol, but we didn't include them in this analysis. We compared them to patients who had a similar baseline sodium, but didn't receive the protocol. And I was actually personally surprised to see this QI data that these patients didn't receive the protocol. And I was like, wow, like we have this protocol, we've had it for years. Why aren't we using it? And so that's one of the good questions is like, okay, we're not using it in some patients. Let's dig into that, find out why. And what can we do to either optimize this or find out what we could be doing better? So the primary outcome for this analysis was the change in serum sodium from baseline to 24 hours. That we looked at the total change, the total numbers, the delta, and the proportion of patients achieving that goal sodium. And so we talked yesterday about our providers could select a delta of 8 or 10. And so did you achieve that goal or not? That's a reasonable metric, I think, for a protocol. And so this is a little bit about what our calculator looks like. This is the Excel output. So you put in the nadir sodium, again, you put in your delta correction, and it kind of, it calculates everything out for you. It also calculates how it's diluted all the components, which is really nice. So we had 9 patients who were on the hyponatremia protocol, 9 that did not receive it. Again, all these patients had a sodium less than 120. They were mostly MICU patients. They were relatively well matched on all their demographics as far as being on the protocol for about a couple of days, et cetera. 56% mortality, which is reasonable for these patients. So our study outcomes are presented here. Nothing is jumping out as extremely statistically significant. It's going to be hard to find a big difference with only 18 patients. But we can see that the patients who were on the protocol in this graph are in red, and they had a less severe increase, a less sharp increase in sodium over 24 and 48 hours, as compared to the patients in blue who did not receive the protocol. And so the conclusion from this analysis was that the hyponatremia protocol patients had a slower sodium correction, The maximum sodium at 24 hours was 122 versus 130, and they were more likely to meet their sodium goals with the custom fluids versus standard fluids, and that was almost significant. Okay, so we're going to move away from the projects that we do on this QI committee and go through a patient case and highlight some of the things that we think about as far as medication selection, safety in these ICU patients, utilizing our medication dosing protocols. So we have a patient, 44-year-old male, 120 kilos, extensive past medical history. It's a totally normal Kentucky patient. He received 8 liters of fluid, no urine output. He's hypotensive, he's ventilated. Here are his labs. So we get started on CVV HDF, and here are the parameters. So we have pre-dilution replacement at 1 liter an hour, or post-filter replacement at 1 liter an hour, pre-dilution replacement at 1 liter an hour, and dialysate 2 liters an hour. The total effluent dose, 4 liters an hour. And the team is starting vancomycin, Zosyn, tobramycin for septic shock and pneumonia, which is very reasonable at our institution. So we do a lot of double coverage for patients who are on pressors, and the literature does support that practice. We've switched from amikacin to tobramycin based off of IDSA recommendations. And so the things I go through as far as teaching this topic to our learners and even just myself and say, okay, what's the GFR of this prescription? What pharmacokinetic alterations am I expecting in this ICU patient? When we're picking out these doses, what is the risk of overdosing versus underdosing? And then coming all together, magically finding the right dose for this patient, right? It feels like magic sometimes. And so we know that higher effluent rates increase removal in CRRT. This is not new information. This comes from this figure here, looking at urea and creatinine clearance. And the effluent rate-based creatinine clearance calculation can be utilized to understand, well, what is the creatinine clearance provided by this prescription? And so you add the dialysate and the replacement rates and ultrafiltration rates. For this patient, we don't have any prescribed UF, which is fine. It's a negligible difference anyway with this calculation. And you convert liters per hour to mils per minute. So you have 4 liters an hour divided by 60, 66 mils per minute. So the GFR of this prescription for medications that are going to be removed through dialysis, we're going to get there, would be around 66 mils per minute. So this is a very reasonable starting place. If you don't know what dose to use for your patients, you can come here, use this equation, and then figure out, based on medication dosing, recommendations from your drug software programs, what kind of dose I would use for a GFR of 66. This patient does have pre-filter fluids. We know it reduces the convective clearance. I've provided that equation here. However, this is very challenging to operationalize at the bedside. So we do not include this into our assessment of the GFR of the prescription. I'm curious, does anybody utilize this when you guys are calculating this out, like in your notes or whatnot? I mean, there's a lot of math we could do, but sometimes you just have to, perfect is the enemy of good. I think this is a great example of this is just too much. So what we do know about this equation is it generally underestimates clearance. So if you're on the verge of a dose change, utilizing the effluent-based creatinine clearance equation, you probably want to round up. But if you have pre-dilution fluids, maybe we would take that into consideration, right? And the next thing we want to understand is, okay, what alterations do I expect in this patient? We've been talking about volume overload last 2 days. A lot of these CRRT patients get CRRT because of volume. There's a lot of problematic things that happen with PK changes in our ICU patients. I don't have time to go into all of that, but specifically related to volume overload, we know this changes the way our medications behave in the body. And so if you have your intravascular volume is third spacing because of endothelial damage, and you have peripheral edema everywhere, you have pulmonary edema, you have brain edema, there goes the water, so goes all my hydrophilic medications. And so they're not in the central compartment, and they're not being delivered to the site of infection. So it's not like the water goes to the site of infection, because that would work really well, right? There's some kind of drug delivery mechanism to make that antibiotic go to the site of infection. I will retire a millionaire for that, right? But it's really problematic because we're basing all of our dosing recommendations on FDA labeled package insert dosing that was studied in like 20-year-old men in the 1970s who just traded a couple of blood draws for Chick-fil-A coupons when these drugs were getting put on the market. I mean, I'm not joking. That's how this is done. You don't need many patients for a PK study. But that does not reflect these patients, these morbidly obese patients, these comorbid patients. Our grandma's in the ICU with really low muscle mass. And so it doesn't translate. And there's a lot of data behind that. I really like this chart here from this meta-analysis from a few years ago. It's just looking at the volume and distribution. And so I always point out the big three antibiotics we use: meropenem, piperacillin, cefepime. The open circles on this chart are the package insert volumes and distribution. This closed square with the line through it is the weighted mean volume distribution in the studies. And it's incredible to me. They don't even meet in the middle. They don't even meet at all. And so these patients in these studies have volumes of distribution of these antibiotics that are 2 times to 3 times higher what we would expect. And for me as a pharmacist, if that volume and distribution just doubled, I should double my dose, right? Based on the Cmax equation, if I want to achieve that concentration in the blood. So we need to understand that. So we need to understand that patients are volume overloaded. The volume and distribution is abnormally high. When we're picking out our medication doses, to me, that means everyone needs a really high loading dose. And sometimes, maybe if you have a patient who is bacteremic already or what have you, you could give a higher loading dose. And that recommendation is making its way into the literature. And so maybe you do 2 doses of Zosyn back-to-back, 2 doses of cefepime back-to-back. So when you have this information, you're gathering it all. These are the medication dosing steps I would look at to understand, well, how am I going to dose this medication for this patient? And so I would go to PubMed, see what's new. Our dosing guidelines are based off of what's in PubMed, not what's in LexiComp or what's in the package insert. And so utilizing that most up-to-date data is going to be important here. In general, convective modalities are going to remove larger substances and equally remove the smaller substances. So it's something that if you had to rank your modalities as far as removal, perhaps you would rank that one higher than the diffusive modalities. And then we need to look at the physiochemical properties of these drugs. So we just talked about volume and distribution. So only drugs that have a small volume distribution are going to be in the central component, in the blood, exposed to the hemofilter, and removed, right? So that cutoff is going to be 1 to 1.5. Some people would say 2 liters per kilo. That would be the max. These medications, protein-bound medications don't get through as well, right? So we're not removing albumin. We're not replacing albumin on the circuit. We're not plasmapheresing these patients or Mars, removal. So anything that's highly protein-bound is not going to be removed either. So limited protein binding, less than 80%, could potentially be removed. Although someone said it yesterday, and they said it really well, there's a lot of protein binding interactions in critically ill patients. And I think we were talking about the vancomycin protein binding is between like 5 and 50%. So what day is it 50? What day is it 5? Right? We don't know. And so some of these other drugs that are highly protein bound have interactions with the hemofilter in these critically ill patients. And we're really at the tip of the iceberg of that kind of data. Then we want to look at molecular size, because we know that the small and middle molecular weight substances are going to be really readily removed through diffusive modalities. Convection is going to capture it all. So if we have larger molecules that sit in that middle to large molecular weight category, your diffusive removal is probably not as good as your convective removal. I don't know how to quantify that any further than that. The molecular weight is inversely related to diffusive removal of the molecule. So as it goes up, your removal is going down. And here are some suggested cutoffs that I've kind of compiled over the years in the literature and from experts in the field. Then we go to our effluent-based creatinine clearance calculation. So we have, okay, we checked the 3 boxes of these medications. Yes, yes, yes. We have a VD that's in range. We're not highly protein bound, and our molecular size is reasonable such that it should get removed. Go to that equation. You can plug it in and you can see what is being recommended for that drug. There are some caveats. We're going to get to them. In general, if you can't do this and you just need to kind of make a big guess, effluent rates greater than 3 liters an hour require higher doses. And that is written throughout the literature by many experts over the years. We also know that pre-filter replacement fluids are going to reduce that convective clearance. And let's not forget about the original kidneys here too, right? So I think sometimes we forget that some of these patients are put on therapy for overdose situations or volume overload, but they're still making urine. They're still making urine with constant concentrate in it, right? And so we could potentially have situations where patients are making good urine and we're utilizing the therapy for whatever we need it for. And so that's kind of a double whammy for elimination medication dosing. So the caveats to the effluent-based creatinine clearance equation are beta-lactam class of antibiotics. So beta-lactam dosing, underdosing is really common in CRRT. So this study suggested that the doses of meropenem, a gram Q12, cefepime 2Q12, and zosyn 4Q6 didn't make the cut. I'm going to have to start speeding up, so I'm going to talk a little bit faster. So these doses, which are reasonable, and this zosyn dose is the full package insert dose. It did not hit the goal of 90% or higher. They also saw clinically significant meropenem accumulation at 48 hours, which we should hold on to because that's been seen throughout the literature. This study looked at beta-lactam dosing a little bit more recently, utilizing a different PK goal. Meropenem, a gram Q8, cefepime 2Q8, zosyn 4.5Q6, so kind of our highest FDA labeled doses. 92% of these patients met their target attainment. 51% had early, exceeded it early, and 58% late. So we're seeing accumulation of our beta-lactams at 48 hours. And they saw that the ability to meet this PK/PD target, or like your goal concentration in the blood, was inversely related to the CRT intensity. So as the CRT dose went up, your ability to meet those concentrations went down. And so this looks pretty good. These data look pretty good as far as these doses would be recommended to meet target attainment. 92% of patients met target attainment. What do we do with aminoglycosides? There's not a whole lot of data out there, but we know that the high dose once daily strategy is beneficial for bacterial killing and for minimizing tubular toxicity as well. And so that's a strategy we should be using for our CRT patients as well. So this is a summary of our amikacin, tobramycin literature. And so the optimal dose of these agents is going to be that high dose, 20 to 25 mg per kg amikacin, 7 mg. Some centers have suggested up to 10 mg per kg, kind of like a CF patient there. Dosing body weight over 48 hours. And so you would also provide therapeutic drug monitoring for this patient as well. Who uses slow zosyn? Slowson. I love that word. I think Katie Russ taught me that word. One of our great nurses in the NICU. So yeah, we do too. So if you infuse your beta-lactams over 3 hours, you're getting a good concentration and you're keeping it there. And that's the goal for beta-lactams. So everybody should be doing that in the ICU. There's so much data that improves mortality in the ICU. Like, just make it happen. Set it on autopilot. When we went to Epic, it was on autopilot, so it's great. But this is a schematic of why you would do that. So it's a balance of safety and efficacy here, right? Because one study said we're underdosing. The other one said, oh, we're overdosing them at 48 hours. And what's the problem with that with beta-lactams? They do have a wide therapeutic index. Generally, we think them as pretty safe drugs. The risk of underdosing is a matter of life and death in these patients. So we know that subtherapeutic cefepime concentrations is an independent predictor of survival in ICU patients. Patients with augmented renal clearance are 6 times more likely to experience therapeutic failure. Suboptimal concentrations below these thresholds that we want associate with development of resistant organisms. And we know that 40% of standard doses are inadequate for achieving this target attainment. There's a lot of problems with underdosing. Excessive dosing, cefepime neurotoxicity. Is this a buzzword in your institutions the way it is mine? I'm seeing some head shaking. Yeah. We don't know what the incidence is of this, but we need to be looking out for this. So you can't just set it and forget it. You need to make sure we're de-escalating based on your bacteria. 2 grams Q8 of cefepime is only needed for meningitis and Pseudomonas and high MIC organisms. So if you have a friendly E. coli or something relatively easy to treat, especially in the urine, we need to be de-escalating within the dosing interval as well, in addition to the drug. Meropenem accumulation and just accumulation of these drugs at 48 hours in CRTs has been shown consistently throughout the literature. And so I would suggest this is a good time point to reevaluate these super aggressive doses we're putting these patients on. And then, of course, we don't have therapeutic drug monitoring at the bedside. These drugs are perfect for it. They're perfectly set up for it. There's a known dose-response pharmacodynamic relationship between efficacy, bacterial killing. We should be able to do this, but it's not ready right now. So I'm going to go through our patient case. So again, our patient was getting 4 liters an hour of CVD-HDF. His GFR is around 66. So what PK alterations does he have? Oh, he is a fluffy Michelin man. So this guy is extremely volume overloaded, right? And he was an outside hospital transfer, so who knows what happened before he came to us. He's going to have reduced clearance, reduced absorption, all the things. So I know that he's going to need really high initial doses. He's going to need very high loading doses. A loading dose of vancomycin is 25 to 30 mg per kg. Those experiments were done in the 1970s with 20-year-old men getting Chick-fil-A coupons. So I would just, boom, give him that, right? Zosyn, 4.5 grams. I think you can make a case, based on everything we've just talked about, to dose those first two doses pretty close together, or give him extra Zosyn, an extra Zosyn dose. Tobramycin, 7 mg per kg dose and body weight sounds reasonable. And then we need to assess these medications for removal. So we want to look at the molecular weight, the volume of distribution, the protein binding, and I have all these kind of listed out. And so yes, these drugs check all three boxes, boom, boom, boom. They will get removed through CRRT. You can consult your drug dosing software at this point. We know the beta-lactams need high doses, so we're going to skip that drug. But vancomycin is very reasonable. So then you could say, well, for GFR of 66, how would I dose my vancomycin? And then you can kind of go there. And then select maintenance doses are at the bottom. So this is my last slide. So I want to also bring back in, this is a multidisciplinary, this is a team sport, right? There's so many people taking care of these patients. Everyone has a role, and we need to be working together to optimize the care. And that's the whole point of our QI committees. That's the whole reason why I'm here today, and why you guys are here today. Communication is so important. We need to leverage our EHRs to make this easy for us, right? So how can we notify pharmacy when CRRT starts on a patient? How do you guys do it? Ooh, did you guys hear that? There's an automatic pharmacy consult. You guys have that in Pike? Oh, nice. We have that as well. Pharmacy to dose. It's like my doctor's favorite order to put in, I swear. Pharmacy to dose, all the home medications. I'm like, come on now. I mean, I'm not sure if this happens all the time. But yeah, that's fantastic. So what about when patients stop therapy? What happens? Is there another pharmacy notification that you guys have? So you have to be aware of the therapy stopping. There's not an automated communication to pharmacy when it stops. Does anyone automate that? How do you guys do it? Uh-huh. Okay. So he was saying his MAR, when they scan the fluid rate, has a pop-up notification for starting therapy. But what about stopping? Yeah, you can DC the order, but who's going to DC the tobramycin dose that's due next hour? That's my point here. So we also have that pharmacy to dose for initiation. We are personally struggling with, how do I notify pharmacy when it stops? And when is a reasonably clinically significant stopping time? Because what if we're just having some clotting, clogging, vascular access issues, and we're going to get up and going a little bit, right? And so this is, I think, an open area as well, something that we should be tracking. You know, we already track dose delivered versus dose, achieved as far as effluent dose, or dose prescribed versus dose delivered. But for a pharmacist, like if that patient had downtime of 6 hours overnight, that is 25% of my dosing interval. My doses need to change. My doses that have a narrow therapeutic range, like aminoglycosides, vancomycin, et cetera. And so there's opportunities here. And I love these sessions because we can talk and learn from each other about how to operationalize this and execute this. I encourage all centers to come up with your own dosing guidelines. Medication dosing guidelines should be available. They should be easy to read, easy to operationalize. We need to be taking into consider changes in the prescription as well. So what do we do at 48 hours when we've been ultrafiltrating pretty aggressively, achieving euvolemia for our patients? Perhaps we've de-escalated the total effluent dose, because my center does do that. So I've not only decreased, I'm shrinking that patient's volume of distribution, also shrinking their clearance. So the total body clearance of all medications is going to go down. And that can be extremely significant in some patients. I have examples that we can talk about later. We're running out of time. But we need to think about that. So we need to be monitoring the volume status as it relates to medication dosing. And one little point I just want to poke into the ether here is all of this data about volume overload and harming patients. No one's talking about the pharmacokinetic implications of that. And these septic patients are being underdosed, and we don't even realize it. And so why is volume overload so bad? Does it have to do with your subtherapeutic Zosyn levels? Yeah, probably. Plays into it, right? So accumulation at 72 hours has been established. 48, 72 hours in literature, we need to be reassessing everything. And then this peri-CRRT period is my last point. And so this was a recent upgrade that we had to our EHR when we moved to Epic. We talked a little bit yesterday. These patients come off of therapy and they have perfect chemistry. Their creatinine is great. Their BUN is great. Electrolytes look great. We're bridging HD with high dose Lasix, so our urine output looks good. I mean, like everything looks good. If you're just going to kind of open that profile, creatinine clearance is 120. Pharmacy to dose bank goes in, right? What do? So if we're not notifying the rest of the care teams, especially the overnight teams that have fewer resources, as we know, this patient could be dosed inappropriately if the system is measuring a GFR based off of his like 1 hour post CRRT serum creatinine. And so I have a screenshot of what we've been able to do. This is available in Epic Foundation. So if you guys have Epic, other centers have done this. We copied the MUSC system, the way they operationalized it. So for the pharmacist storyboard, if the patient came off of dialysis, had an active, discontinued, or completed order for either hemodialysis, peritoneal, of course, a little bit different, or CRRT in the last 96 hours, this warning pops up. Because we do have some patients who get HD like twice a week in our hospital. And we still need to know, okay, what is their clearance? It's not a Cockcroft. We cannot use Cockcroft and Galt here. It's like totally inappropriate. And so it says the creatinine is 3, this patient's on dialysis. And that's been really nice for us. And so this is something that we're going to roll into our QI program as far as a patient-centered intervention. Hopefully we're improving medication dosing around this CRRT timeframe.